All right. Well, thank you for that introduction, Dr. Staudinger. So I have the pleasure of giving you guys a talk today on one of the cadaveric projects that I've been working on over the last 6 months or so. I want to start out initially by saying a huge thank you to Michaela and Ben. This project was not an easy project. The dissection was pretty intricate. There were lots of dissections. There were lots of measurements that we had to take. So this definitely would not have happened without their support. And I also want to thank Dr. Butel for helping us with some of the clinical correlations of this. One of the things that I've learned over the course of the last year is that it's easy to come up with a cadaveric question, but until you link it to something clinically, it's tough to really get anybody else to kind of care about it. So his approach to this and his guidance in this is something that's been pretty much invaluable. So with that, we can go ahead and get started. The talk today is going to be about the anterolateral ligament of the knee. And we specifically were looking at if adaptations existed both in structure, anatomical structure or kind of gross anatomy, and in histological structure as well. Just to get started, we're going to start with a quick anatomy review. We'll then discuss some of the contradictions that exist within the literature. We'll go over our specific studies' aims. We'll then look at our results, and then we'll finish off with our clinical application and then some limitations and some future directions. So this project, like I previously stated, is about the anterolateral ligament specifically, but that ligament is part of what's called the anterolateral knee complex. There are actually 4 structures that make up this knee complex, the first of which and the most proximal is your iliotibial tract or your IT band. Your IT band itself is actually made up of 2 distinct parts. You have your tensor fascia lata muscle, which is in yellow in the image on the right. That is the most proximal area or the most proximal aspect of this structure. It goes from the anterolateral iliac crest to the middle of the thigh. And I said roughly there because because that's not super important for today's talk, and because it's variable in each individual donor. The structure that we care about for today's purposes is the distal end of that IT band. And this is just the fibrous component. It's what's in green. And this is what goes from the middle aspect of the thigh down and inserts distally into Gerdy's tubercle, which is on the anterolateral tibia. Let me move this out of the way. Good. So important to know is that this iliotibial tract, especially the fibrous band aspect of that, is continuous with the deep fascia or the crural fascia that circumferentially surrounds the muscles of the thigh. Moving a little bit distal, right? So now that we are specifically looking at the knee, we have our distal IT band insertion. This protects against some varus instability. So I guess you could say this aids in varus stability of the knee. We also have our lateral collateral ligament, which originates on the lateral femoral condyle here and inserts on the head of the fibula. This also aids in varus stability. And then the last structure, I guess not the last structure, but the important structure on this slide and today is the anterolateral ligament, which is termed the ALL. This also originates in a similar spot as the LCL here on the lateral femoral condyle, but inserts more anteriorly into Gerdy's tubercle, which is on the anterolateral tibia. Now, the function of this ALL is considered to be a secondary stabilizer of knee internal rotation. So the last aspect of this anterolateral knee complex is our knee capsule. There's really not a whole lot to this structure. It's the deepest structure. We can kind of see it peeking through this image up here on the top. I like this picture on the right because it really does a good job of showing the layers of all these structures. The first thing that we discussed was our iliotibial band or our IT band. We can see here that is the most superficial layer, and it kind of inserts, it's pretty variable. It inserts anywhere from the lateral aspect of the patella all the way down to Gerdy's tubercle, which is where we kind of care about its insertion there. Underneath our iliotibial band, we can see our ALL, and we can see our LCL here as well. FCL is just fibular collateral ligament, which is what it's synonymous for, or I guess another name for it. Okay, so now that we've done our anatomy review, we can discuss kind of where this problem, or I guess this question, arose. If you look at the ALL within the literature, there is lots of contradictions. There's lots of kind of conflicting info on most aspects of the structure. So if we're looking from a gross perspective, the first thing I want to talk about is the prevalence of the ALL. In some studies, the prevalences have been anywhere from 100% to 0%. So we don't really agree as a community yet if this is present in everyone. If it's not present in everyone, we're really just kind of up in the air with how many patients we should expect this in. There also seems to be some discussion on the fact that the prevalence values between formalin embalmed cadavers and between fresh frozen cadavers is different, which I thought was kind of interesting. We'll go through that here in a little bit. Secondly, the morphology of the ALL is also something that is conflicting, right? There is studies that describe it as more of a sheet-like band structure. There are studies that describe it as more of a tubular structure. So there's just a lot of info that is up in the air regarding the anatomy and just some of the characteristics of this structure. Beginning with the prevalence, this was a systematic review. I wanted to initially discuss the difference between the fresh frozen cadavers and the embalmed cadavers in terms of prevalence. So the fresh frozen cadavers here are highlighted in blue. These are all, they're much higher than they are in the embalmed cadavers, right? The majority of these ones that are highlighted in blue show a prevalence of about 100%. I don't know why there's a difference between fresh frozen versus embalmed donors, but it was just interesting to see that this distinction is known and has been made within the literature. If we go over to the embalmed cadavers, which are now in green, the prevalence within these or this donor population definitely is lower than what is presented here in the fresh frozen cadavers. Again, not quite sure why, but our donors that we used were embalmed. So it was just kind of important to bring this up initially as a way to really wrap our heads around kind of what our project was about. In terms of origin and insertion, there also is some differences of opinion and differences of, I guess, just knowledge of where this thing is. So there's a lot of, I guess, conflicting info, like I've mentioned before. We can see here in red that there just is not a lot of agreement on where this originates, or now in orange on where it inserts. I will say the tibial insertion of this is much more consistent compared to the origination. I don't know why, but that's just kind of where we're at, or where we were at before we underwent this project. Our next point of conflicting info is involving the classification of this structure. So on the left, we have one of the papers that describe this as being more sheet-like. We can see the head of the LCL or the FCL inserting onto the head of the fibula here. This is the ALL, which in this image is, I guess, more sheet-like, right? It's more fibrous. It's more of kind of a band. Whereas on the right-hand side, the ALL, which is much smaller, this is just how it's described and seen if it's viewed as more of a tubular structure. So again, not quite sure the methods of both of these papers didn't seem to go too in-depth on their dissection methodology or protocols. So I'm not sure why this is as different as it is, but just interesting nonetheless. So getting into our study's specific aims, there were three, right? We'll start with the first one. The first aim of the study was to further understand and add to the existing literature in terms of prevalence and morphology. So we initially had 80 formalin embalmed knees. After exclusion criteria were applied, there were 49 knees that were included for measurements and for the analysis. And just a brief description of our dissection process. We started by reflecting the IT band distally off its insertion onto Gertie's tubercle. The LCL was then identified and marked at its insertion on the head of the fibula with a T-pin. This next step is in bold because this is one of our inclusion criteria as to determine if it was present or absent in the donors. And this is where we added some internal rotation to the knee to determine if distinct fibers ran in the direction of the internal rotation. Once that was done, the ALL, if present, the origin and the insertion were marked with a pin. And then we kind of retro dissected to the proximal origination of the LCL. We also used some palpation and some varistress to just kind of further help figure out where that LCL runs. This is an image of what we had in our lab, and I'm actually going to zoom in so we can see this a little bit better. So this left image here is more in line with what has been termed a tubular structure. So we can see here in white is our LCL. The structure marked by the black pins is our ALL. And this is tubular, which means that it is It's thicker than, I guess, the sheet structure on the right. But one of the things I want us to look at is the fact that we really can't see this metal pin underneath like we can over here, right? This looks almost translucent because it's just a lot thinner than it is in the tubular structure. This medial structure is what we have deemed sheet-like, and I guess what others have deemed sheet-like as well. Like I said, white is the LCL, our black is our ALL, and again, this is thinner because we can actually see that metal pin popping out underneath the tissue. So it's more translucent. And then as we go over here to the right, this is one of our knees that we have deemed ALL deficient. So we can see with my cursor here, this is the LCL. We do see tissue that is going maybe in the right direction on top of the LCL, kind of like this one is. But the reason I included this picture and the reason I wanted to mention this distinction is the fact that previously when I said we added some internal rotation to the knee to help determine if something was there or not, we can clearly see the fibrous bands of this structure are directly in line with the internal rotation as we rotate. In this knee, even when we added some internal rotation force, nothing distinctly popped out like it does here. So that was one of our criteria, even though that there is tissue in the correct spot, right? It's superficial to the LCL. When we added that internal rotation force, we really didn't see a whole lot in terms of a distinct tissue structure, which is why we then have deemed that ALL deficient. Let's zoom out. Okay, so just discussing some of the morphology and the frequencies from our study, we have found that the ALL is present in 31 of our 49 limbs, which is a 66% prevalence, or I guess a 63% prevalence. This was pretty close to some of the other prevalences that we've discussed, especially within embalmed donors. So we were happy with that process, and we were happy with the results of that and how it looks compared to previous studies. We did find 2 that were tubular in nature like this, but the majority of the ALLs within our lab were more sheet-like, more fibrous, as we can see here in this middle image. The second study's aims really is kind of where the novelty of this project lies, right? The first study, nothing is new there. We were just trying to see if the results in our lab matched previously known and previously completed studies. But now the second aims, 2A and 2B, are really where the novelty lies within this project. Our second aim, 2A, is basically trying to understand if, because of the fact that there is incomplete prevalence, do adaptations exist within ALL deficient donors? So 2A is all about the gross anatomical perspective, where we actually measure the length, the width, the thickness, and the cross-sectional areas of some of these structures to see if adaptations existed when you compared ALL deficient donors to ALL present donors. So how do we do this? To determine what adaptations may occur, right? Like I said, we took various measurements of the LCL and the IT band. Down here, it's just a little easier to understand within kind of table format. The measurements we took of the LCL were length, thickness, and the width. The length was just its origin to its insertion, but we took thickness measurements at its proximal, middle, and distal areas, as well as width at its proximal, middle, and distal. And because we had thickness and width measurements, we were able to calculate a cross-sectional area at each of those three locations. Now, we felt the need to calculate cross-sectional area because we think that is a better representation of some of the structural abilities of this anatomical structure, right? The higher the cross-sectional area, the more tension it can withstand before breaking, right? The more stress it can take. Important to note, we also measured the IT band thickness, and this was at the area that the IT band crosses over the ALL. Super big table, right? These are all of our measurements, but I want to highlight 4 specific measurements, and they are our cross-sectional area measurements. On the left side here are our ALL present donors. On the right side are our ALL deficient donors. And the first thing I want us to notice is that all of our ALL deficient measurements, specifically regarding cross-sectional area, were larger in deficient donors than they were compared to the present donors. Only 2 of them were significant, which are highlighted down here on the right, or I guess the bottom right of the screen. But the fact that all of the deficient measurements were larger than the present measurements to us was a sign that adaptations do occur from a from a structural perspective. Now we have our second, or I guess this is our third aim, but our second aim that involves adaptations within the donors. This is where we'll spend most of our time today. This is definitely more of the technical aspect of the paper. We are involving some histology stains and some histological analysis. So there's a fair amount of information that we can go into on these. I think these are super interesting. Regarding the histological perspective, the two measurements that we wanted to find were the collagen density and then the overall collagen quantity of these anatomical structures when we compare ALL present donors to ALL deficient donors. While we were dissecting, we took samples of the IT band, the ALL, the LCL, and the joint capsule, and we sent them to the biorepository at the University of Missouri. They were great. What they did was they actually sliced these tissue samples at a thickness of 4 micrometers and then stained them with 2 separate stains. The first one was a hematoxylin and eosin stain, or H&E, and this helped highlight just the general architecture of the tissue. We didn't do any analysis of that. That was just more of kind of a control within our project. But the second stain is a picroserious red stain, otherwise termed serious red. And this is a collagen-specific stain. So the reason that we had them perform this stain is because this is what gives us the ability to actually analyze it. From a histological perspective, once we received the stain slides back from the biorepository, we took bright field images of the stain slides at both 4x and 10x magnification. We then used ImageJ software to analyze the images and try to quantify these different aspects of collagen that we were looking at. Like I mentioned previously, we looked at two. We looked at the collagen quantity and the collagen density. Now, when looking at collagen quantity, we had to get somewhat creative with how we chose to analyze these. So in parentheses, I have percentage of coverage within a region of interest. We'll discuss a little bit more about what that means and why we chose to do that. But I do want to point out that differences within the tissue architecture made it difficult for us to determine collagen quantity for the joint capsule specimens themselves. And we'll go a little bit more in detail on what that really means and why that was difficult. So for a histological analysis perspective, we followed the protocol that was listed by Dr. DeBroy, who had done something similar to quantitatively analyze collagen content from a tissue sample. Important to note is the fact that this protocol was designed specifically within liver tissue, and that was almost problematic for us. We really had to be creative with how we then translated this to more of a connective tissue structure. So like I just mentioned, there were a couple issues with our application of this protocol. The big one was the fact that there was a difference in tissue. So the liver tissue contains much less collagen than the connective tissue that we were looking at. Just to give you some numbers, liver tissue contains healthy liver tissue contains anywhere from 1.8 to 2.1% of collagen, whereas the LCL, which is one of the structures we're looking at, is 75% collagen by dry weight. Another issue that we had was the fact that Dr. DeBroy's images did not contain any white space. Our images contain lots of white space just because of some inconsistencies with the staining method, with the slicing methods. The images turned out for us differently than they were in Dr. DeBroy's initial protocol. Okay, so diving into one of our quantitative methods, this one specifically was talking about the sample's percentage of coverage within the region of interest. Here we have a sample of our LCL that was taken at 10x magnification. As we can see here, it's uniform, right? We see collagen strands going in, kind of the longitudinal aspect as well as the transverse aspect. Like I mentioned before, there's a fair amount of white space within this image, right? We see some white space here. We see some white space all the way down the middle. We see some white space there. The addition of that white space really makes this difficult to analyze. So one of the ways that we circumvented this was through a region of interest, or an ROI. And what that really looked like is we just toward the center of the image in a location that looked uniform, we were able to take just that part and zoom into that. Therefore, we're basically eliminating all of the white space within this sample. We then converted that image to black and white, and then allowed ImageJ to go through and quantitatively analyze the percentage of coverage, or I guess our percent area within this image. So we understand that this method, right, by using a region of interest, we introduced a fair amount of bias within the study. But one of the ways that we tried to keep it consistent was the fact that we made sure that there were always at least 25,000 pixels within our region of interest that were being analyzed. For example, this small section here had around 85,000 pixels. So there were a couple, as you'll see a little later on in the project, there were a couple tissue samples we had where it was very difficult for us to find a similar amount of pixels that we could analyze, but we did find at least 25 pixels in all of our samples. The second section, or I guess the second aspect that we were looking at, that was percentage of coverage within our region of interest. The second one involves tissue density. But before we really can discuss how we went through that, we need to talk about the concept of thresholding within image J. What thresholding does is it allows us to choose which pixels within an image that we actually want to include for analysis. And it does this based on the mean gray value of each pixel. Now, this can be a manual process in which I'm the one that decides the thresholding criteria, or this can be an auto thresholded process in which the computer itself decides what it thinks it should include and shouldn't include. Like I said, this is how we circumvented the differing amounts of white space within our image for our density calculation. And we can go through that next. So again, this is the same 10x image of our LCL, right? We have the same amounts of white space that are present. When we undergo the auto thresholding feature, what ImageJ does is it tries to distinguish, is this an upper half or a lower half in terms of pixel intensity, or I guess in terms of mean gray value within the image. So when I hit auto on this button, this is what pulled up. So we can see here in this graph, all of the pixels that locate beneath 128 of a mean gray value are now in red. There's still a fair amount of tissue here that is showing up in gray that is not included if we only included these. So we chose to do a manual threshold in which I was the one that actually went through and changed, right? I changed this value from 128. I moved the cursor up to 155. Now, all of the tissue that we have in this image is what we'll be analyzing. We can still see that all of the white value that is present in the initial image is not being included, right? Those pixels are not being taken into consideration. So this is one of the ways that we were able to figure out what is the density of collagen within only the pixels that were representative of our tissue sample. So now that we've discussed thresholding, we can go through kind of a little flowchart of our collagen density protocol. Again, we have our initial image. We converted to black and white. We then thresholded to only include the pixels that are located within the tissue. And we were able to calculate our mean gray value of just those included pixels. The scale for this is 0 being black and 255 being white. And it's important to understand that because if we think back to this initial image, the darker areas allow less light to come through on a bright field image, which means that is actually closer to black than it is to white. Therefore, the lower mean gray value is what actually insinuates that there is a higher density of collagen within the structure. This is just a quick comparison of a couple pictures, right? LCL, this is the same picture we've been discussing for the last few minutes. This is a pretty good sample of our IT bands. The thicker colors here is actually not more collagen. It's just the tissue has been folded over a little bit, making it seem like there's more collagen there. But the reason I wanted to include this slide is because this is a image of what our joint capsule looked like. As you can see, it would be very difficult to actually analyze that from a density perspective, from a region of interest perspective, right? The looking back on this square here would be probably the most amount of tissue we'd actually be able to analyze. And this is one of the better images of joint capsule. So we chose really to not look at joint capsule for a whole lot of our analysis. I also wanted to point out that the increased white space within this image made it difficult for the camera to really keep colors consistent and to focus, right? Both of these colors are very consistent, right? We have some oranges, we have some pinks, we can clearly see some dark red compared to light red. all of this looks bright red. And I really do think that the reason that this is the case is because there is just so much light coming from underneath the microscope that it made it difficult for the camera to really determine what was light red versus dark red. So just a couple reasons why we chose to really only do our analysis on the LCL and the IT band. And here are our results of that discussion. So again, ALL present knees are on the left, ALL deficient knees are on the right. When we looked at our intensity, intensity is our mean gray value, right? More collagen is a lower number. So this right here, this value of 107.9 is lower than 116, which means that our ALL deficient knees actually within the LCL contained more collagen, or I guess a higher collagen density than our ALL present knees did. And this was significant at 0.04. Again, looking at the LCL, our region of interest percentage of coverage was also much higher in our ALL deficient knees at 44.7 than it was in our ALL present knees, and that also was significant. When going down to the IT band, the intensity again was higher in our ALL deficient versus ALL present knees, not significant, but approaching significance. And within our IT band, the percentage of coverage was significant with a higher value in deficient than in the present knees. We did look at the joint capsule intensity. Again, that was a little bit easier because I was able to manually threshold those images. They were very consistent. So I don't know if that means that there is not adaptation specifically within the joint capsule tissue, or if that was just the result of the fact that the camera struggled really differentiating between heavier and lighter stains because of the amount of light that was able to pass through with all the white space. Interestingly enough, I did include just our ALL intensity values, just so we could see where this fell on the spectrum. Looking at our ALL, our intensity had a value of 106.9, which is actually containing more collagen than our LCL and our IT band. And our percentage of coverage was pretty similar. We had a 40.3% of coverage compared to a 45 and a 44 within the ALL deficient knees. So just to wrap this up, some kind of concluding statements. From a prevalence perspective, this study agrees with other prior studies that have determined that the ALL is not present in all individuals. The study also agrees with prior studies that there are two distinct morphologies of the ALL. But we did, one of the conclusions of this paper specifically is the fact that we did find adaptations within ALL deficient knees, both in terms of gross anatomical structure as well as histological content compared to ALL present knees. This adaptation may be compensatory in nature, indicating that the ALL may play potentially a more significant role in lateral and rotatory stability than what was previously thought. So, like I mentioned initially with Dr. Butel's input, all of this is great. All of this is super interesting. This histological stuff is cool, but why should we care about this as clinicians? These are two statements that were taken from recent papers that are discussing ACL repairs. The first one says combined anterior cruciate ligament and ALL reconstruction is associated with a significant reduction in ACL graft rupture rates, no increase in the risk of reoperation, and a very low rate of complications. Important to note, just from this first one, right? This is discussing doing an ALL repair the same time you do an ACL repair. This is not something that is commonly done, right? Sometimes the ACL is the only thing that is repaired, and they just leave the ALL broken or damaged, or they don't include that in part of the reconstruction. A second study mentioned, despite remarkable advances in the clinical outcomes after ACL repair, residual rotational instability remains a major concern. So we are discussing the fact that the ALL plays a role in rotational stability. Combining these two sentences, we're hoping that this really persuades orthopedic surgeons to consider making combined ACL-ALL reconstruction the gold standard. Right? We've shown that adaptations exist within ALL deficient knees, suggesting that the ALL plays a much more important role in stabilization than that was originally thought. Because of this, we recommend that all ACL repairs and reconstructions should include a component of ALL reconstruction to address the rotational instability that is commonly seen after ACL repairs. So great that we found adaptations, but I think if we're able to think about these adaptations in a way that help understand post-op complications and post-op outcomes, specifically with ACL repairs, that's kind of the niche that this project falls into. A couple quick limitations, right? The tissue sections that were done at 4 micrometers. This might have played a role in the difficulties with the tissue architecture. If we think back onto that slide that I showed the image of the joint capsule, if that was done at 5 micrometers, that might have prevented some of that white space. Tough to tell. So we were happy with the fact that our IT band and our LCL was consistent enough for us to be able to analyze. So, silver lining there, but we're curious to see how a 5 micrometer thickness might have affected either the results or just the ability to include the joint capsule. We also had a sample size of 49. I think within all of cadaveric research, sample size is something to consider and something to be cautious of. And our histology sample size was only 36 knees. This was a result of both funding limitations and the fact that we did include a fair amount of knees from the Joplin campus as well. So histology was only sent from knees within Kansas City just because it was much easier for us to get those samples dissected out and taken, just because we were, as KC fellows, we spend way more time in that lab. So that is all that I have for you guys today. I'm happy to answer any questions.